Hello, and welcome to Communication and Behaviors Part 2, The Good, the Bad, and How to Support Creative Interventions, presented by me, Kelly McCarthy. So here's our overview. Person-centered focus. Who makes up that valued team when supporting behaviors? Manifestation of a need or a distress. And that's also known, so AKA, also known as behaviors. We're also going to talk about introducing new people and places, navigating through behaviors, and then identifying, are we looking at a pill or should we really be looking at a plan? And at the end of the day, what are the person's brass rings? So many people are familiar with the person-centered care approach. This is an approach that focuses on the persons, and if you look to the left, it says they're medical, right? So any medications they're taking, their diagnosis, any surgeries, any restrictions that they have. Their social, how they communicate, how they navigate through their environment, their preferences, their day-to-day routines, and then their life story, the good, the bad, and yes, there can be the ugly. So if you look at this on the right-hand side, these are some approaches that are based on my book, which is the Northbridge's Person-Centered Care Approach, the brass ring. So what I'd like you to do is I'd like you to take a few minutes to discuss with the proctor in the class about what are brass rings, who has them, what happens if you don't reach them, and then what are peacock moments? And do you only give them out to residents or do you give them out to each other? And then I want you to talk about the iceberg. What's on top and what's underneath? And when you know the stuff underneath, what should you do with it? And how does it help you be a better caregiver in using that person-centered care approach? So do me a favor, put yourself on pause and go through that with your proctor before going to the next slide. So here's person-centered care approach. This is kind of just one example that I've used in the past. Having that individual right in the center. So person-centered care approach. Let's go around. First, you'll see that family and the family caregivers. They're very crucial to the person-centered care approach. They have a lot of that home history, right, and the habits and the like. You got the first responders right after them as those individuals in the neighborhood. Maybe some support groups. So this might be something that the family's getting some support with. Then those primary care physicians, and again, when I ask in my classes, who are the experts, this is what you guys point to right away. The nurses, the doctors, the medical field, right, the specialists that support them. And I want you to be open-minded that they're not the only experts, right? Those families are the experts, absolutely. Those primary care specialists are the experts. And look at this, just after medical history, which is really important that we gather from the physicians and the like, and the families, you're the expert. So if you look at caregivers that support the day program or residential living program, you guys know and understand the habits, the rituals, the routines. You know that history, the home history. So the more we know, and we say this to families all the time, the more we know, the more you can share with us what's under your loved one's iceberg, the more successful they're going to be. So understand that you're the expert too. Doesn't mean we get it right all the time, but the more we know about an individual, absolutely we're doing the right thing. So this slide talks about the benefits of a solid team. So think about your neighborhood. Think about the people that you work side by side with every single day. And kind of think about those benefits. And if you'd like, if you have your proctor there, put us on pause and take a minute to just kind of think about the benefits that you have in the community, the residents, how do the families feel with a solid team, and the like. So if you have a few minutes, you can pause. And so what I think, and so we'll go over this, is the health and well-being of the person's number one. Absolutely, when you have a strong team, that happens. How about yourself, right? You always feel more confident. You feel that you're valued by your community. And you also feel like you're a part of, right? So you belong, and that's huge in an organization and in a community like that, as well as being open-minded to different viewpoints can create success. So this is when I say that we want to be really mindful that everybody and everybody's viewpoints matter. So Everyone is a caregiver in our communities, regardless whether you are a frontline associate in care, if you're a housekeeper, if you're culinary, nursing, maintenance, programming, engagement. All of those individuals and those titles are so crucial. And so we really want to make sure that, let's say, for example, clinical teams are open-minded to non-pharmacological approaches. And then that non-pharmacological approach team, like let's say engagement, really is open-minded to the clinical aspect of the expertise, right, of our teams. So just really being open-minded about that. Everyone has a point of view that must be respected. Patience and follow-through with interventions is so important. So when you identify, and you're a solid team, and you identify challenges within the neighborhood, maybe that is causing a behavior for someone, you really want to make sure you have patience and that you're keeping consistent. So for those of you who have been in my class before, I often talk about creating a habit. So take a break and answer this question amongst yourselves. How many days does it take for us to establish a habit? So how many days does it take for you and I to create a habit? And then that next question is, how about someone with memory loss? So hopefully you're on break and you already got these answers, but I'm going to give them to you. So it takes about 21 days for you and I to make a habit. We can establish a habit within 21 days. Individuals with memory loss aren't that far off. It's about a month and a half, so it's about 35 days or so, and depending on their cognitive ability. And so this is a game changer for us when we're caring for someone with memory loss, knowing that novel learning, they can create and make new habits. So I'll give you an example. If you have a resident who they join the family, they join our community, and we bring them to the dining room table 3 times a day, breakfast, lunch, and supper. We do it now for 35 days. Breakfast, lunch, and supper, we bring them to that dining room table. What happens after 35 days or 40 days? Where do they go when we walk them to that dining room? So if your answer is the exact same table, most likely the exact same chair, we've just created an experience where they've retained a habit. And again, that's a game changer when we're looking at individuals that we're caring for, because we can support a process where once we identify a challenge, if you're a solid team, you can work together, be patient, follow through, and create habits for our residents. So this actually starts the beginning of a chapter that I have in my book on behaviors. I thank God for behaviors, because if we didn't have behaviors, we would not know what the person's trying to tell us. So behaviors are absolutely a form of communication. It is that person trying to tell us through a need or a distress. And that's why we use that word, manifestation of a need or a distress, because really it's about a way or a form of communicating. All right, so now we're going to talk about behaviors, aka manifestation of need or distress. Whose behavior can we change? I'll give you a few minutes. I'd like you to discuss that. Whose behavior can we change? If the answer is we can only change our behavior, that's important to note, right? And sometimes people that want to have control over changing their behavior don't even do that very well themselves. So just be mindful that the only person's behavior we can change is our own. Is it a problem? So to give you an example, and I say this in my live trainings, is that I brush my teeth in the shower. Yes, it's a habit. It's a behavior. I have a behavior of brushing my teeth in the shower. And so don't judge me. Just know that about me. Is it a problem? It may not be socially acceptable, right? Not everybody does it. Some people might think it's not a good idea, but is it a problem? And so we really need to look at the individuals and say, listen, it may not be a problem. It may be not socially acceptable, but is it a problem? And so that, to answer your question, isn't. But are they causing harm to themselves or others? That's the game changer. That's one. Unwanted sexual contact. So that's another. And impeding the functioning of the day. When they're disrupting the day, whether it be verbal or just not able to get the day off the ground. Maybe there's a programming that's supposed to go on, but because of a one particular person, it's not going on because of that behavior. So those are some of the reasons why we really want to make sure that we can really support, and they're just a few, there's more than this, but kind of harm to themselves or others, unwanted sexual acts, and impeding the functioning of the day are really ones that we definitely have to focus on. Do we have anything for this person? When you hear that, what do you think they're saying? So if you answered, they're looking for a pill, right? They're looking maybe for a medication that can try to manage that behavior. You're absolutely right. And that's not what we want to do. So if you've ever heard that, here's some behaviors or some habits that people may have that cause people to say that. So wandering. Again, if I've had a history of walking and I want to wander, or I feel the need to physically exert myself because I'm, whether I'm anxious, right, or that I want some exercise, there's aimlessly walking, walking without an agenda, and then there's walking with an agenda. There's causing harm to themselves or others, as we had mentioned. Exhaustive crying, which actually comes from a deficit or a deterioration of the frontal temporal lobes. Hoarding, shopping. Again, hoarding is a negative word. It could be that somebody has a habit of shopping and will go into others' rooms. I often talk about the story that I have a history of going to hotels for over 10, 12 years for work. And I used to take the shampoos, the conditioners, the soaps, and I'd put them in my bag and bring them home. So fast forward 85 years old and I have memory loss. What might you think if I go around trying to take everyone's personal hygiene products, which should be secure, by the way? What happens then? So my daughter won't be upset with me. She'll actually look at me because she knows my history. She knows what's under my iceberg, and she'll say, "Score, Reverend Patty, you'll be very excited about that." So my history is that I would grab all these products, throw them in a bag, and then when there was a flood in New Orleans or an earthquake in Haiti or a fire in Texas, whatever the tragedy or the disaster was, we would have a local truck come and pick up all these supplies from our church donations, and I would always throw that bag in there of individual products. And so if you didn't know that about me, you'd consider it hoarding. You might use a negative word to describe my behavior when in fact it's a part of my history and I'm trying to tell you something. These are just great examples, and try to think, maybe if you want to take a few minutes to think about all of these and why we might have these challenges, like a catastrophic reaction. Well, if we're in the shower and somebody's trying to bathe us and that's never happened before, how would we feel, right? Not protecting ourselves, exhibiting inappropriate sexual behaviors, just to name a few. So these are some of the things that we may be looking for a pill when in fact we really should be looking for a plan. Which leads me to my favorite slide. Instead of a pill, let's think about what's causing the behavior, because that's where we can start to look at a plan. Is the task too demanding, too complicated? Is the environment too noisy, right? Or is it too boring? Does the person feel frightened? Are we trying to get them into our reality? Are they tired, hungry, lonely, or in pain? So if you think about these things, if a task was too demanding or complicated for you, would you give up? Would you feel frustrated? If an environment was too noisy, would you be overwhelmed? I know I would, right? If I was frightened, I would most likely maybe lash out or be scared or angry or fight or flight, right? If somebody was trying to get me into their reality, I think that knowing that if somebody has memory loss, how challenging could that be for them? And then again, they might not tell us that they're hungry, tired, lonely, or in pain. And so these are things that we need to be looking at as well. So instead of a pill, think about what's causing the behavior. These slides are so beneficial. And I think that even though you may have seen these before, if you've done the brass ring or any of my other classes like part 1, I repeat this because it's worth repeating. It is in fact a game changer when you're thinking about individuals as they progress. So this is the bookshelf. It's the amygdala bookshelf. And if you look at this, the hippocampus is on the left-hand side of the bookshelves, and then the right-hand side is the amygdala. The amygdala is the part of the brain that supports emotions and feelings and those memories. So again, this is so important. So I'm going to go over this. A healthy brain weighs about 3 pounds. So if you look at this on the left-hand side bottom, you've got childhood, teenage years, adult, middle age, and old age. So that first left-hand side, that hippocampus, this is where we learn logic, fact, and reasoning. So our primary colors, learning numbers and counting and letters, learning as we get older, learning a profession, right? Maybe getting into either a technical school, going to further education in college, a vocation, learning to run a household. All of these logic, fact, and reasoning, be able to communicate with individuals, right? On the right-hand side is the amygdala. These are the feelings. So I often think about my childhood memories, and I think about Halloween and how I used to get those really big candy bars and how fun it was to go around my neighborhood and then go with my brothers and barter, swapping different candies. There's happy, there's traditions, but there's also scary things that could happen. So things that are under our iceberg that could be tragic are also under that feelings, emotions, and memory side. So it's important to know that it's the good, it's the bad, it's the ugly. And that is typically on that emotional side, that amygdala side, when we think about that. Again, healthy brain, 3 pounds. Here is early stage memory loss, when we have a brain that is just starting to have dementia. So when people start to have dementia, what happens? They start to repeat. So this is maybe somebody who at the age of 85 may say, what time is supper? What time is supper? Right? And so when we answer it like, I told you already, don't you remember? It's 5 o'clock. Or maybe not even intentionally being rude, but maybe being condescending by, oh, silly, I told you it's 5 o'clock. So if you think about this, the books are off the shelf on the hippocampus, but there are no books off the amygdala. Now, because there's no books off the amygdala, that means their feelings and their emotions are still intact. So if somebody looked at you and said, I told you already, it's 5 o'clock, you just forgot again, how would that make you feel? So take a few minutes out. You can pause. So I don't know about you, but it would make me feel, right? It could make me feel angry. It could make me feel embarrassed. It could make me feel sad of beginning stage memory loss and I know it's happening. So we really want to be mindful that even though somebody's early stage memory loss and they're starting to forget, they still have their feelings intact. Now here's middle stage memory loss. So this is where somebody has a lot of their memories kind of in old age, that have forgotten certain years in middle age and adulthood. But look at their amygdala. The emotions and the memories of experiences, right, of people are still there. So, for example, let's say a boy meets girl at childhood and they live in the same neighborhood and they're best of friends. Maybe in their teenage years they start dating. He goes off to the military and she stays home. But before that, they marry and she's pregnant and she starts to raise a family and he comes back. And now they start to live their life. He works. She maybe runs the household, the good, the bad, and the ugly on that right-hand side. So the birth of children, right? The death of individuals. Again, arguments, bad things that could happen, beautiful vacations, all of that's on that right-hand side. So look at now, she's 85 years old and he passed at 84. So does she forget him? Or does she forget the fact that he died? So if you answered she forgot the fact that he died, you're correct. Because she still has a lot of the memories. She may not have specific things in adulthood and middle age with logic, fact, and reasoning, but she still has that amygdala, the feelings, the good things and the bad things that might have happened within their lives. So sometimes you'll hear somebody say, have you seen my husband? Do you know where my husband is? And if we look at them and say, your husband's dead, what do you think they would think or feel? So if you think that if you say that they've mourned all over again, you're right. They could say, oh my gosh, nobody told me. They could cry. They could get angry. Who are you? I had breakfast with him this morning. Who the heck are you telling me that? So there's a lot of emotions, right? They could be sad. They could be angry, anguish. So it's important to be mindful of that. I'm going to give you a quick story. I had a gentleman who walked by me. I was on my way to stand up and he said, hi, chum. That was his nickname for everybody. Hi, chum. And his nickname for everybody to tell him was chum. So it was service planned. We didn't do it without having it in the care plan. So I said, hi, chum, how are you? He goes, okay. He says, do you know where my wife is? Now, I knew his wife died 11 years ago, and I knew that he knew it when he first came to live with us. So I noticed now, boy, there's a change in mental status. So I looked at him and I said, you know what? It's 8:15. I bet you she's in school. She was a school teacher for a local school. And so he looked at me and said, oh, okay. And he walked away. What do you think I did? Do you think I just kept that information to myself? If your answer is no, you're right. I didn't just keep it to myself. Not only did I put it in the communication log, not only did I talk to the teams that were with me that day, I talked to the nurse because we definitely saw a change in mental status. And so I'm going to see if you guys would be able to answer this. Although I'm not there, how many of you know what the nurse might do because of a mental change in status? What might we think is wrong? So if you answer a UTI, you're right. So that's the first thing that we did. We pulled a urine on him to see if he had a urinary tract infection. And in fact, he didn't. This was a part of his disease process and his journey. At that moment, the book fell off the shelf and he did not know that she had passed. And so one of the things that we did to do was work with the family on identifying, because we knew that his amygdala, his thoughts and feelings were still intact, that we needed to work as a team to identify a fiblet, which is a therapeutic lie that decreases anxiety to support him. And one of them was, she's at school or she's with her daughter up in Maine. So again, you have to work as a team. It's not something that you should be doing on your own. And incidentally, if a fiblet works, who do you tell? I hope your answer was everybody, because that's the case. And if a fiblet doesn't work, who do you tell? Same answer. Fiblet, you always want to tell whether it works or whether it doesn't. And don't just throw them out haphazardly. Definitely work with your teams and work with your director to say, hey, listen, I'd like to try this. What do you think? Because it definitely takes a village to make sure that we're doing it right and making sure that we're person-centered and we have the right approach. End-stage memory loss. This is an individual who, as you can see, a lot of the books are off the shelf. On the right-hand side, though, the amygdala, there's still books on the shelf. That person at end-stage memory loss can still feel. So we talked about the fact that a brain is 3 pounds at the beginning of this disease, and a healthy brain is 3 pounds. What is it at the end? Anybody want to guess? So if you said 1 pound, you'd be correct. So the healthy brain is 3, and an end-stage memory loss, it shrinks. There's less fluid in that brain. There's less viscosity to be able to shoot neurons across that brain. So that person has a really difficult time, as you can tell with this bookshelf, but they can still feel. So this is where, let's say it's 3 o'clock in the afternoon and you're doing your rounds and you go to do your hourly checks and you're looking, and instead of knocking on the door and walking in and saying hi to this resident who's end stage, you just look to see if their feet are on the bed, they look calm and quiet, then you walk out. Without addressing them or talking to them for long periods of time, they can still feel isolated. They can still feel lonely. They can still feel sad. Individuals with late stage memory loss, you got to remember that they oftentimes can sleep more frequently, and there's less periods of lucidity. Getting in there and holding their hand and talking to them, maybe singing a song, are beautiful for those one moments to make them feel safe, because they can still feel that, right? Let's talk about maybe if they're in their bedroom and it's 2 o'clock in the morning and you have to change them. You know that this is now a time that you need to change them. Maybe you need to move them a little bit. And so now you go in, maybe there's 2 people, you're talking, and you go in and you put your hand under to go and change the brief or get them ready to be changed. You turn the light on, you don't say hello. How do you think they'd feel? Right? So if your answer was, because you look at these bookshelves, there's a lot of feelings here. So if your answer was they can feel violated, they can feel scared, they can feel frightened, right? They can feel, let's say they have something under their iceberg. Let's say they have a sexual abuse under their iceberg, right? The good, the bad, and the ugly. They can feel violated, right? They can feel threatened. So just be mindful that as the end-stage memory loss, we want to make sure that we're connecting with them and that we're really looking at this and seeing the opportunity we have when we look at individuals that can still feel, right? They can still belong, they feel love, feel all of the emotions. So here we are, end-stage memory loss. This individual, you knock on their door, you go in and maybe you caress their hand and you tell them who you are. Hi, it's Kelly. I'm here and just want to make sure you're okay. I wanted to sing you a song. This little light of mine, I'm gonna let it shine. This little light of mine, I'm gonna let it shine. This person can still feel love. They can still feel safe. They can still feel valued. So this is a non-pharmacological approach to care. These are just some examples. So if you think person-centered, do they like gardening? Do they enjoy being outside? Some things that we've done in the past would be laminating maybe some postcards and pictures of their local town, places they enjoyed visiting to be able to reminisce, washable playing cards if they enjoy solitaire or playing, or even sorting if they're a cognitive ability that they're not able to play cards, but they can actually put like suits together. Sorting cards are so great. Baby clothes, so, looking at some individuals may like to see onesies, maybe some booties that they can sort and put together. Will allow them to reminisce. Now, again, this is person-centered, non-pharmacological person-centered. It's not going to be for everybody, but it can be for, again, identifying what they really like. I've done a fishing reel before where I've actually cut the fishing reel to just be very small and have the tick, 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 right? I take all the line out, but I give the tension for in about a couple inches. And it just makes it really kind of neat. People reminisce about fishing, talk about saltwater fishing or freshwater, what kind of fish and the like. Baby dolls. So you don't have to get a $200 doll, but it definitely is a nurture nature concept. I have a story in my book about this. And so I've seen baby dolls relatively inexpensive at Walmart for $9.88. They have to have eyes open, eyes closed. That's important. Eyes open, eyes closed baby dolls is a great way to identify a swaddling in that nurture nature. Weighted animals, or for real kitty, the for real dog, or weighted animals that have a scent is that aromatherapy. So if you have, I have a cat, and when that cat sits on my lap and it's it feels weighted, it's warm, I rub, I'm rubbing that cat, it decreases anxiety. So those are some of the things that we could possibly do in our neighborhoods. So at the end of each chapter in my book, we'd have takeaways. So this is for home-based caregivers, and really it's just to share with them how important it is that they share what's under their loved one's iceberg. So what's in that social history? It really does help us as caregivers. The more information they share, the more successful we'll be because of that emotional connection that person will feel, and it allows us to hopefully, right, create some successful redirections. So in regards to redirections, this is something that's taken right out of my book that I work through when we are looking at interventions in your neighborhood. So if you look at this, there's 4 factors that a team should be working on. And that is behaviors, is that number 1, which is what the behavior is. The 4 factors are physical, psychosocial, emotional, and caregiving. It's important to make sure that we're not using judgment words when we talk about behaviors. We shouldn't be saying he's mean or she's nasty. Those are judgments and do not belong in our neighborhoods, do not belong when we're talking about the behavior itself. So when I say she's combative, is that a behavior? So if you answered yes, it is. But is it enough to know? Do we need to know a little more about the behavior? Not only when does it happen, where does it happen, and the like, but what is it combative mean, right? So I'll say, let's say she's kicking, or she's punching. She's not kicking, she's punching. She's using her fists. So that's the behavior. She's combative, she's punching, she's hitting, she's flailing her hands. So then we're going to look at these and identify, okay, is there anything physically that has gone on with this lady, maybe within the last, month or so? When we look at medications too, I always like to look back. Go back about a month, because there's some medications, even 3 months, some medications that have to build up into your system. So look back. So physically, I ask, anything physically gone on with her? And maybe the answer is, yep, she fell about 3 weeks ago. She went to the ER. They did an x-ray. It was negative. They've had her on Tylenol, and they brought her back home. Okay, so we know that. The next thing is, let's go across the way and look at caregivers. Is this happening every time this individual is getting up or around, or every time we try to, go over to her, or is it just one caregiver? And so the answer is, it's every caregiver, and it's absolutely every time we try to get her up, get her moving. So I'm sure you're thinking about, okay, what's going on here? We're asking questions, and it sounds like something's going on physically. So environmentally, she's not wanting to take showers. She does not like moving off the bed. But environment, there doesn't seem to be anything wrong. It's more that physical we're talking about, and it's happening to all caregivers. Psychosocial, she's angry, very upset. Does not express to be in pain, but she definitely is upset. So what we decided, and this was actually a true story, is that we went and had the physician order another x-ray, and there was a hairline fracture that was missed, and this person was in pain. So it's important to really rule out that medical aspect of it, because this person was acting out and getting aggressive, not because she was mean or she was nasty, right? That judgment words that we should never use, but it was because she had a hairline fracture that was causing her discomfort, major discomfort. So again, looking at these 4 factors really does make us are able to really help them and focus, really pinpoint on the possible challenges this person might have. So now we're going to talk about transition huddles or intervention huddles. These are things that we would like the communities to do, and home office is always here to help you. Intervention huddles are real-time huddles. They should be time sensitive. So once you start seeing a behavior in your building, don't wait to let us know. Really kind of get in there. We'd love to do them within 24 hours. This can be weekend, week, it doesn't matter. We really want to make sure that we can get these huddles done in a timely manner. So within 24 hours of a behavior is a good thing. Invite key players and host either external or internal or external. So key players, right? So you think, yep, that's the nurse, that's maybe the ED, but make sure you get those frontline associates too, because if the behavior is happening during your shift, we should make sure that we involve you, because you're a key player, right? And we're going to talk to you, we're going to ask you questions about it. It's never, when I do huddles, if I do them or if your team does them, they're never, hey, what did you do wrong, right? We're never accusatory. We just want to ask a lot of questions to see, what could we have done differently and how can we support this resident? So the benefits of an external huddle, which is someone like myself or your regional care teams as well, is that we have a 10,000 vantage foot, which means foot advantage, meaning that I've been doing this a while, and I've had experiences in Yuma, Arizona, and Walla Walla, Washington, and Sheboygan, Wisconsin. And what I realized was that the things that were happening there also happen here. So some of the interventions that we've put in place there might be something that we can utilize and try here too. So having people like myself or a clinical team, because they're overseeing all of our buildings, and if it's happening in your building, it most likely or may have happened in another building, and so using us as a resource is really great. Always follow up, identify a timeline. So once you look at, hey, listen, let's look at this intervention, let's try this. Don't just let it go and say, okay, let's follow up in about 3 weeks. We know a habit takes about how many days for somebody with memory loss? If you said 35, you're right. So it takes about 35 days. So really kind of make sure you're following up and regrouping on it. To continue, here's some pitfalls. So oftentimes I hear why huddles don't work is that they feel like I don't have enough time to do this. I'm busy, right? Well, you can't afford not to have time. This is the 6th leading cause of death. There's no cure, there's no treatment, there's no prevention. They do now have a medication that's actually slowing the process of the disease along. So there is hope. But the fact of the matter is, they're still looking at 1 in 3 of us getting this disease. So I say to you, how lucky do you feel? And then how do you want to be cared for? I always hope people have time for me when it comes to being able to do a person-centered care approach. Not inviting the key players. So again, making sure that the people involved in that behavior at that time are on the calls or in the interventions. Then sometimes people are afraid that they have to come with answers, like, oh, we have to be there and we have to have answers. No, I want us to really focus on questions. It's all about questions, not about answers. We'll work together. We'll look at books, we'll look at their charts, and we'll identify whether, the answers. But it's about coming up with questions. Do you think this would work? Do you think this would work? What's going on here? And just kind of working around those 4 factors that we talked about earlier, right? Physical, environmental, caregiver, and psychosocial. You want the chart, behavior logs. I like them to be time specific if possible. If we keep a behavior log for months and months and months, no one writes on it or no one looks at it. But if we identify a behavior log for a specific amount of time, especially if it's a behavior that's happening for like 1 week or 2 weeks, we can really kind of uncover what's going on, who's in the room when it's happening, what's being said, what time of day. So, and then pulling that log and really taking a look at it, stopping the log and really looking at what we see within that picture in time. Looking at the medications, the weights, the vitals, social history and preference form, and then also an open mind to other people's opinions and beliefs. You always want to follow up, right? So we talk about this. You want to give all parties time. I'd say at least I always say a month and a half. I know 35 days. So just making sure that we got it down. Maybe after a month, take a look at it, or a couple of weeks, take a look at it. Keep tweaking it. It might not look the same as what you originally did, but really making sure that we create a habit and look at that specific time, and then regroup. So this slide talks about colors and the importance of colors, what sometimes colors how they can play a role in communicating and in behaviors. So if you look at those highway signs down the road, the fluorescent green, those are good to see. They're easy to see, and they're also been identified in the UK as one of the last colors we lose the ability to see. So fluorescent green is a nice tip if you're going to do a sign, a picture of a toilet. It's just a bright color and easier to see than others. Black can be conceived as scary and hard to see. I go back to my Looney Tunes day when I was a kid, and you would see Bugs Bunny take a black hole out of his pocket and then throw it, and it would land on the ground and he would jump in it. Because black can actually look like a hole. And so it can be perceived as a hole. And so these are colors that we try to stay away from. Purple can go missing. So there was a study done in the UK again, identifying purple, and I don't know if it's because it's a regal color or it's one of those colors that tend to, if somebody does like to rummage and grab things and kind of put them in their bags, that's the color that will go missing first. There are 3 colors that are active colors. The first one is red. Red, orange, and yellow. These are colors that get us up and going. They increase our appetite. They can also be agitators. That's why if you see increasing our appetite, if you think about McDonald's, Chick-fil-A, KFC, Wendy's, you're looking at a lot of red. Sometimes you'll see yellow in the Burger Kings and McDonald's. Those two colors are, they'll increase your appetite, and oftentimes can by 27%. But you'll never see a jail cell painted red, because they also is an aggravator. And so this can get us going, but also can get us upset. So be mindful of that when we're caring for our residents, that large doses of red are not good. Small doses are fine. And you'll see it in our new plateware, where we have a little red rim that goes around the plate, and it shows contrast, and also, again, being that appetite, increasing their appetite. Blue is an appetite suppressant, so it decreases your appetite. So I like this. This is a case study. So let's kind of talk about this, and I hope that we can kind of have you pause and kind of reflect on the story. So case study. Author is a 79-year-old man who lives with his wife, Fran. She is having difficulty getting him into the shower. When she asks him to take a shower, he says, "No, I don't want to go, and I already took one." Or maybe he'll say, I didn't do anything to get dirty. And I know sometimes we probably hear this ourselves in our communities. Because of his response, Fran, though, gets agitated. She hasn't had the classes that you guys have, and she's getting frustrated. So she even says sometimes she tries to shame him into the bathroom, telling him he stinks. And of course, what does he do? He digs his heels in even more. And now Fran is really upset and comes to us because she doesn't know what to do, because she's having a hard time with this behavior. So the first thing I say is breathe. Is it a problem we need to even address? So yes, it is. It is definitely a problem that we need to address, or in a situation, but it doesn't have to be a shower. Maybe getting him in and keeping him clean by sponge bathing, right? Or getting him, but our goal is to get him into the shower. That's going to be number one. But if we have to land on doing other things and washing him up another way, it's okay. But let's shoot for giving him a shower. So after talking with Fran, we identified that she has a son who lives right next door. She has the physician that has been working with him because it's his primary. And then he has a daughter that lives far away. And so these are the team members that we work with Fran. So now going back, looking at these 4 factors, we know that the behavior is he's resisting to take a shower. So now we're going to look at these 4 factors. So if you look, physical. Author has arthritis and does not have full range of motion of his legs due to stiffness and pain. He has had difficulty at times with depth perception when it comes to colors of similar color. Similar colors. So think about it. A bathroom. Typically a toilet is what color? A sink, a shower chair, a tub, right? The bottom of the shower or a tub. I'm sure you're thinking about the same color, which is most likely white. And so that's going to be perceptually a challenge for him, right? And he also has arthritis. And if there's a lip going into the shower, that can be a challenge as well. So here is the bathroom is cold until the shower is on. There's a small lip entering the shower. The shower chair and the shower stall are both white. Fran becomes agitated and frustrated, and at times Arthur does not recognize his wife. Arthur gets agitated with Fran, right, while she's communicating with him. There are times where he feels his privacy is being invaded because he doesn't recognize Fran. So here are those 4 factors, right, really breaking down, kind of looking inside. So now let's review environmental and physical. So this is where you might take some time to think about what are some of the things that you can do environmentally and physically for him. So he has arthritis. The water is cold, right? I mean, the room is cold before he takes a shower. He has some visual challenges. So what are some of the things? So here we have this is putting the shower on prior to him getting in the space. The pain, maybe getting him some arthritis medications 20 minutes before getting him into the shower. So it makes it easier for him to step over that threshold. Visual challenges, so maybe paint contrasting strips or some tape on the lip of that shower on the step to go over. And then the chair. right? And this is inexpensive, putting over maybe a color, favorite towel, maybe lime green goes over that chair so that he's able to sit and has a good target for that place. Then put bright, so the bright blue or whatever his color is. So caregiving interventions. So they decided that because he's a little agitated with his wife, that the son who lives next door is going to come once a week and shower him, and he's also going to have his favorite soap. And I believe they also had a favorite song that they sang. So Arthur's son volunteered, right? Because he's successful, Fran's stress decreased her stress. And Arthur's psychosocial needs are being met and supported because his son is giving him a shower instead of his wife. And the son, even though he may not remember his son, he's reminiscing. And just a nice guy's giving him a shower, and they're singing some songs that he's reminiscent of, and he's using the favorite soap that he had. And so he's really making sure that they're into fine detail. This is where the family will talk about interventions, and so they regroup. Did it work? Did it not? What do we need to tweak? So it was really a success story. So when you think about this, what are the brass rings? I can only imagine feeling at home, right? Feeling that they belong, peace of mind. This is all I think about Fran, and I think about her husband, making sure that there's contentment, there's forgiveness, right? We don't always get it right, but Fran really saw the impact that her son had on this collaboration, right? And so there's appreciation and the like. So I hope you enjoyed this program of brass ring behaviors in communication part 2. Have a great day.